Hello and welcome. I'm John, and this is an EBO podcast exploring one of the most practical challenges in modern healthcare delivery. How do we make access to local services simpler, clearer, and more productive? In this episode, we look at a single point of access and navigation solution being proposed through Project SPAN and what it could mean for patients, carers, staff, and the wider NHS. Sharon, thank you for joining me. Let's start with the basic issue. Why does access and navigation matter so much right now?
Thanks, John. It's great to be here. So, it matters because the NHS is moving in the right strategic direction, but that can still feel complicated from the patient's point of view. Services are becoming more connected across neighbourhood teams, community care, primary care, diagnostics, acute pathways, pharmacy, and wider local support. That is a positive shift. But when the local offer becomes broader, the navigation challenge becomes harder. People may not know where to go, whether they are eligible, who to contact, or what the next step should be. And when that happens, they often contact multiple services, default to the most visible route, or simply disengage. So access is no longer a minor front door issue. It is becoming a central operational issue.
Yes. Right, that makes sense. So when we talk about the solution here, what exactly are we describing?
We are describing a trusted digital access point where patients, carers, and in some cases staff can ask questions in natural language and receive locally grounded answers. So, the purpose is simple: help people find the right service, the right route, or the right next step without unnecessary confusion. The project is the vehicle for deploying and evaluating this approach, but the deliverable itself is the single point of access and navigation solution. Its role is to reduce friction, improve first-time routing, and make the local healthcare offer much easier to use.
And it is just as important to say what it is not, isn't it?
Very much so. This is not an open-ended assistant, it is not a diagnostic service, and it is not there to replace clinical judgment. It is tightly bounded around routine questions on access, eligibility, service routes, contact details, opening times, next steps, and common appointment-related queries. It can guide someone, it can explain, it can signpost, and where needed it can support handover to staff, but it is not there to offer unmanaged clinical advice. That discipline is one of the reasons the model is credible.
Right. Bring that to life for us. What kinds of questions would it actually handle in practice?
Very practical ones. Someone might ask whether they can self-refer for a service. They might ask where a clinic is, what to do if they have lost their appointment letter, whether an appointment has been made, or whether a referral has been received where that can be supported. They may simply need to know which team to contact and how. These are everyday questions, but they matter. They are often the same questions that drive calls, inbox traffic, reception interruptions, repeated explanations, and frustration for patients and staff alike. So although the queries are routine, the operational impact is not small.
Okay, let's turn to the tech, because that is where many people will have questions. Why is generative AI relevant in this particular use case?
That is a fair question. It is relevant because this is a highly document-rich environment. The information already exists, but it is often fragmented across trust website pages, service information sheets, referral criteria, patient letters, FAQs, contact details, and other local materials. What generative AI does well, in a use case like this, is make that content usable at the point of need. Instead of forcing a person to search across multiple pages and piece the answer together themselves, the solution can generate a clear, human-sounding response based on trusted local content. That is especially valuable for local signposting. Because local signposting only works if the information is not just present, but understandable, accessible, and easy to act on. So the AI is not inventing the service logic. It is making approved local knowledge easier to access and easier to understand.
And that leads to the obvious concern. How do you stop something like this from hallucinating or going beyond what it should say?
Quite simply by constraining it properly. That is the key principle. The solution is grounded in approved content, safeguarded prompts, retrieval from trusted sources, and clear escalation rules. So the answer is not simply trust the model. The answer is to design the operating model so that responses are grounded, bounded, auditable, and able to hand over when needed. If a question falls outside scope, or requires human action, or raises a safeguarding concern, the response does not improvise. It escalates, signposts, or hands over. That is how you make generative AI useful in healthcare, not by making it sound clever, but by making it safe, disciplined, and locally reliable.
Got it. Okay, that is a very important distinction. So what's the patient touchpoint? Is it the trust or neighbourhood website? Is that the right place to start?
Yes, and that's because it is the most practical, often Googled, and controllable starting point. A trust website gives you a clear initial channel, designed for mobile use and accessible to a wide public audience. It also allows the organisation to deploy in a measured way, observe real demand, refine the content and routing, and build confidence before considering wider channel expansion. Over time, there may be options to surface the same experience elsewhere, including through the NHS app, but starting with the website is operationally sensible.
Let's come to patient benefit. So, if this works well, what changes for the person trying to get help?
What changes is clarity and confidence and speed. Instead of waiting for office hours, trying several routes, or reading through multiple pages, the person can ask a straightforward question and receive a clear answer based on local pathways. That may sound simple, but it can make a real difference, especially for someone who is stressed, unfamiliar with the system, supporting a family member, or unsure what they are entitled to access. A good access layer reduces anxiety and helps people act earlier and more appropriately. And that matters because confusion about access is one of the quiet ways a system becomes both inefficient and inequitable.
Yes, and that naturally raises the staff side of the equation. What changes there?
Staff get time back from repetitive work that does not need to sit with them in the first place. That includes inbound calls, generic mailbox queries, reception interruptions, repeated signposting, redirected contacts, and avoidable walk-ins. But there is another point here as well. When something does need human follow-up, the handover can be more structured. So the solution is not simply deflecting demand, it is improving how demand is handled. And that matters because administrative teams and care coordinators often absorb the friction created by fragment access. If you reduce that friction, you release staff time for higher value work.
The solution must have a fairly confident ROI case. Right? What makes it credible?
It's credible because it is built on real operational levers rather than speculative claims. The value case is based on reduced manual demand, improved first-time routing, fewer repeated answers to routine questions, lower admin handling time, less avoidable footfall, and better structured follow-up. In other words, it focuses on areas where inefficiency is already visible. That is what makes the return plausible, and often up to 3 times return.
And the value goes beyond administration, doesn't it?
Yes, absolutely. Better access does not only save time, it can also improve flow across the wider system. If people understand the right route earlier, they are more likely to self-manage appropriately, seek the correct support sooner, and avoid unnecessary deterioration or unnecessary contacts elsewhere. It can also reduce avoidable GP appointments that are really about signposting, referral clarification, or basic navigation, especially where direct access routes already exist. So the benefit is not just administrative channel shift, it is a broader improvement in how people move through care.
One of the more interesting aspects, I think, is the insight layer. What does the solution produce beyond the interaction itself?
It produces intelligence about demand. Every interaction can help reveal what people are asking, where they get stuck, which services are least understood, where escalation happens, and where repeated confusion is generating avoidable workload. That means the solution is not only a front door, it is also an insight layer for service improvement. Over time, that can inform redesign, highlight unmet need, improve communication, and support wider neighbourhood planning. So the value is not only in answering today's question, it is also in showing the system where tomorrow's friction points are.
And is this intended as a single deployment or something more repeatable?
The ambition is clearly repeatability. The project is designed to test and prove a model that can be reused. Once the governance, content approach, reporting framework, and operating model are working well in one setting, the same principles can support wider rollout across multiple services and potentially across a neighbourhood or ICB footprint. That is important because this is not just about launching a tool, it is about proving a scalable approach to access.
Final question, Sharon. If you had to summarise why this matters in one clear thought, what would you say?
I would say this. As care becomes more connected, access has to become more intelligible. If patients and carers cannot understand the route in, the wider model struggles. What makes our solution compelling is that it applies generative AI to a real and bounded operational problem, grounded in approved local content, governed by clear safeguards, and linked to measurable productivity and system value.
Brilliant. Sharon, thank you very, very much.
Thank you, John. It has been a pleasure.
And thank you for listening to this EBO podcast on making access to healthcare simpler, clearer, and more responsive through a single point of access and navigation solution.